And welcome to this video snippet on critical reasoning, bias and error and their correction. Basically, we're all prone to bias and we're all prone to making mistakes. So this is actually a fairly important video, and we'll try to deal with how we can mitigate the effects of these things. Let's have a look at a few definitions of bias. Bias is not prejudice. Prejudice is prejudgment. That means that you're never going to change your mind after you've done it. Bias, on the other hand, is much gentler, and it's unconscious. And it really is that you move towards the conclusion that you would like to see come out. The difference between this and prejudice is that you can overcome bias and have a much more rational decision made. The other thing about bias is that it is not necessarily a bad thing. Most of your decisions made during the day come about through heuristics, and bias is the basics of these heuristics. A heuristic is a shortcut to making shortcut to making a decision. For example, let's take dogs. I've had two experiences with Great Danes, neither of them great. One wanted to eat me and I had to keep them away from me with a sheet of plywood, and the other one wanted to eat my dog, which is a small thing, and one bite would have killed it. It makes me tend to not go near Great Danes. I don't trust them, so my tilt is don't go there. Other people on the other end love Great Danes and they have no trouble at all about cuddling up to them and everything else. It's a different heuristic for different people. It works for me, and if you ever come across a really nasty Great Dane and you've got the opposite view, it ain't going to work for you. Anyway, this is what bias is. It can be good and it can be bad. With clinical decision making, it can also be good and bad. And in fact, with pattern recognition, which is done properly by an expert, a lot of this is about a heuristic caused by bias. Error, on the other hand, is not due to bias. It can be, but generally speaking, you would give it a term bias. This is about being badly informed, incorrect information given to you. You misinterpret the information. That can be due to bias, not listening to what's been told you, but hearing what you want to hear. But it can actually be you're distracted when you're being told this type of thing anyway. So an error is an error. And you can overcome this somewhat by experience and paying closer attention to what you're learning. So bias. This is a form of confirmation bias, but pretty much all bias follows these two things. You get objective facts and you have your belief system caused by previous experience, indoctrination, and so on. And they overlap. And where the overlap occurs is where you make your decisions. If your bias is huge, then your decisions are going to shift over to that side. If it's less huge, then it's going to shift over towards the objective fact sides. But what you see isn't necessarily the truth. It's based a lot on your beliefs going into it. This is completely unconscious, but the correction and elimination of bias has to be a conscious effort. And we'll see how we can do that. So most of the things you see about reducing or eliminating bias comes down to platitudes. This is a good example. Don't be afraid. Know that your ego doesn't want you to expand. Think for yourself. These are all inspirational quotes. There is nothing concrete there to help you. If you want mind to expand, you must be okay with disagreements. Ask good questions, keep information channels open. The last two can be useful, but they're not written very well. So this is all airy-fairy stuff that really doesn't help you deal with it. We're going to look at some concrete ways, hopefully more concrete than these anyway, helping reduce bias in clinical decision making. So we're going to be looking at a few biases, the ones that probably affect us more in our job than any of the other ones do. First one is confirmation bias. This is where what you're hearing confirms your beliefs. And if it doesn't confirm them, you twist it around until it does confirm them, and you throw out stuff that doesn't confirm your beliefs. Anyway, to overcome this, first of all, you never, ever want to be completely happy about any conclusion you reach. There should always be some doubt in your mind about this may not be right. If you're actually feeling very happy about this, it means your endorphin system's been triggered and you're happy because it's confirming what you want. Anytime you see that clinically, you want to be worried about it and have a good look at the information. One way to deal with this is to actually do differential diagnosis, 3 or 4 differential diagnoses, maybe a couple that fits the information you think you've got, but a couple that don't. And you can test each differential diagnosis. It's all mentally done by a single question or maybe a test, and you can include an expert. And as a DDX becomes more credible, then you need to start thinking about your original diagnosis and look at that DDX more closely. Talk to other people about this. Not everybody's going to have the same confirmation bias. And if you talk to other people, they may well tell you that you're wrong, as simple as that. And also be critical of your treatment results. You want those results to confirm your belief that you know what you're doing, and you'll twist the results around until they do. I've seen a lot of patients from other therapists, and this has exactly happened to them. So that's why you come to see me now rather than sticking with the other one. And the answer usually is, he kept telling me I was getting better, and I really wasn't. This isn't deliberate, it's not fraud or anything like that. This is simply the way people's minds can work. Availability bias, basically you make your decisions based on the most available information you have. And this happened to me a lot when I first started doing this. I'd go on a course and then for weeks afterwards, all I would see would be that diagnosis. All that diagnosis suggested was that treatment. And then it gradually tapered off and it ends up going away, that type of thing. So one way of looking at this is review what you've been doing recently. Has this case been described in a previous or a recent course, reading or anything else? Look at the number of cases you've seen of this recently as a cluster. So clusters are not normal. So if you're seeing clusters, this may be due to availability bias. Also, again, differential diagnosis, same thing, go over each case, test it with a question or a test and see how it works out. Priming or framing occurs when you get information prior to actually looking at the patient, and that actually frames you. It puts you in a position where you're going to narrow down the information you're going to take notice of. It primes you for a particular condition. Now, what will do this is the physician script. Don't look at it. Seriously, do not look at it. Not until you've looked at the diagnosis. Don't look at lab or imaging studies for exactly the same reason. Do not speak to a person who sent you or read the referral from another PT or any other source. Go in, when you look at the patient, go in completely open and blank. No previous information. What you get from the patient is what's important, not what somebody else thinks it is. Anchoring is a big one. And anchoring is where you cling to a single or 2 pieces of information, and that makes your decision, and that's what you hang on to. You anchor to it, and every other piece of information that comes in washes over this, and you stick with that regardless of what's coming in. My experience is that this often happens because of the overwhelming amount of information you're taking from the patient. And this is where you're taught to do it. You're told to ask every question, do every test, and make a decision at the end of all this. Preferably don't make any decisions on the way through, wait until all the information is in. That doesn't work, and it ends up doing this. So it's probably not your best idea. Differential diagnosis will help you reduce anchoring bias. Regression to the familiar. This is where you don't really understand what's happening. You're getting information in that's conflicting and that's not making a lot of sense to you. And you start shaping square pegs into round ones so they can fit into oval holes. Don't do this. It's as simple as that. But take notice of the fact if you aren't getting to the point where you're not sure what's going on, you don't know what's going on. Don't try and continue from that point on. Stop, start again, get somebody else to have a look, chat to somebody about it. But don't keep going when you really are not sure what's going on. It's just not worth it. I can guarantee you, if you're more than halfway through the exam and you still don't know what the problem is, you're not going to find it in the next half. So just stop, take a breather, step back, ask somebody to have another look at it, and then go from there. Differential diagnosis should be done after you finish the exam, just to, especially under these circumstances, to make sure that you haven't sort of gone back to a favoured diagnosis. Dunning-Kruger. Dunning-Kruger is actually, it involves both novices and experts. The more ignorant you are, the higher the degree of confidence often is. It's an inverse relationship. More ignorance, higher confidence levels. The reverse is true with experts. As more and more information comes in, your confidence in your decision goes down. Now, the reason for this is that the novice is too stupid to understand how stupid they are. And so they think they're right. And in the face of odds, they believe they're absolutely correct. The expert, on the other hand, as they get more and more expert, understands this is a complex subject, there's a lot to it, and they may not have the right answer. Now, the two lines will cross again as the novice gets more expert, their confidence comes down, and as the expert gets more and more expert, their confidence goes up. It's interesting how the expert's confidence will never ever reach the same level as the novice's expert, exhibiting the Dunning-Kruger effect. So once you've finished and you made a decision on the exam, on the diagnosis, treatment, prognosis, or whatever it is, if you're completely and utterly positive that your conclusion is correct, it's almost certainly wrong. And this applies to any so-called expert who tells you that as well. Do not trust somebody who is completely positive in their abilities and in their decision-making. That's about all you can do, is just watch it and determine how confident you are. You shouldn't be that confident. And premature closure is basically when you stop the exam before you should. Now, if you look at pattern recognition, when it's done by an expert, it's usually very, very accurate, and it's very rapid. The studies that have been done with physicians would suggest that an expert physician will make a diagnosis, a correct diagnosis, within about 15 seconds of seeing the patient. And there's no reason why that wouldn't apply to all healthcare practitioners, including us. But when that goes wrong, it can go very, very, very wrong, especially if the practitioner isn't good enough that he's escaped the Dunning-Kruger effect. So the only cure for this is to finish off the exam. Now, you don't need to do that with everybody. Just on the more difficult patients, or when, again, you're absolutely convinced of your decision. So most of this is about, don't be too happy with your conclusions, don't be absolutely confident in your conclusions, and if you are, then think about exactly what's happening, because you should not be. So I hope that helps, but bias is an important topic. You've got the tools to find your way through this, but bias will screw it up every single time. And we're all loaded with it, and we've got to be careful with it. Most of the cases you see will be fairly straightforward, but a few of them are not. So as I say, basically, don't be overconfident, don't be happy, and if you're feeling overwhelmed, accept that and have somebody else have a fresh look at it for you. Okay, I hope this helped, and I will see you again in another video. Take care. Bye.